Hello guys, and welcome back to new video on EM images part 2, and we'll look at some images in this video. If you look at these two images are quite common to be seen in exams, in the board exams. You will see, given a scenario about an alcoholic male is being brought in after persistent vomiting or was found unconscious, and then on the left side you see that there is extensive surgical emphysema over there, and sometimes they may even put in some broken ribs around on the left side, but surgical emphysema, so some air is coming out from either a pneumothorax or a pneumomediastinum. On the right side image, you classically see the air under the diaphragm. This guy can come in with abdopain and peritonitic, and there is an air under the diaphragm. So let's move to the next one. Next is orthopedic imaging. There's one on the right and one on the left. Okay. If you look closely to the thumb metacarpal, it's broken over there into quite a few pieces. Here it's broken into two pieces on the left side. So which fracture are we considering? These are all unstable fractures at the base of at the proximal end of the thumb metacarpal, and on the left is Bennett's fracture, which is not a comminuted fracture, whereas on the right is Rolando fracture, which is a comminuted fracture. A schematic version is given over here. Bennett's fracture, a single fracture. Rolando is a comminuted fracture. Now this is a gamekeeper's thumb. So somebody skiing and the ski got stuck and the thumb was hyperextended, and what we see is an avulsion fracture over there at the ulnar collateral ligament. Ulnar collateral ligament, the joint between the metacarpal and the proximal phalanx. This is also an unstable fracture and must be referred to the orthopedicians. Now this is a 14-year-old guy who's come in after he punched a wall, and you see a fracture over there at the distal end of the little finger metacarpal. And the important thing about it is not the name, it's just a Boxer's fracture. The important thing is about the rotational deformity. How we remember how much is acceptable? In the little finger, about more than 40% of rotational deformity is not acceptable. So how we remember is 40%, 30% for the ring finger, 20% for the middle finger, and 10% for the index finger. Rotational deformity is not acceptable and should be referred to the plastics. Next, this is commonly seen a mallet finger, avulsion of extensor tendon. Extensor tendon will avulse and take that chip of the distal phalanx, and the patient will present with a flexed distal interphalangeal joint. You need to put them in a mallet splint, and they can be followed up with the orthopedic clinic. Now these three images are the one on the left. If you see, this is a dorsiflexion, and we can't make out, it's basically Colles fracture. And if you see dorsiflexion of the palm, then it's a Colles fracture. If you see a volar displacement, then it is called as a Smith's fracture. And if any of these have an intra-articular involvement, if any of them, like for example here there is an intra-articular fracture, it is called as Barton's fracture. Now Monteggi and Galeazzi, very unstable fractures commonly seen in the exams, these pictures. Now, the thing is, how do we remember Monteggia, which bone is broken, versus Galeazzi, which bone is broken? Both are unstable fractures and need to be referred to orthopedician. Monteggia is ulnar fracture. Okay, Manchester United is the mnemonic, and the other one is the other one. Galeazzi is the radial fracture with ulnar displacement, ulnar dislocation. Now, this is a shoulder joint, and if you look onto the left image where it says, if you look at the inferior glenoid, there's an avulsion, and they have marked an arrow on the top of the humerus, and they are asking us which lesions are these. These are the lesions commonly seen with shoulder dislocations, and the one on the top is Hill-Sachs lesion, and the one at the bottom of glenoid is called as Bankhart's. How we remember is you are on the top of the hill, whereas the river bank is at the bottom. Now this is Maisonneuve's fracture. Maisonneuve's fracture is quite a complex fracture. It is very unstable. If you see, there is an avulsion of deltoid ligament, and the syndesmosis will be disrupted, and the membrane between the tib fib will be avulsed as well, and there will be a proximal fibular fracture. This is Maisonneuve's fracture. This needs to be referred to orthopedics immediately. Now this is tibial plateau fracture, very classical. The common complication which happens is compartment syndrome. Need to think about tibial plateau fracture. Now here it's not very clear. If you look closely just on the top of the fibula, you will see a small avulsion over there. So it's not just an avulsion fracture, it carries a huge amount of clinical significance. It's called as a Sigand fracture. It's called a Sigand fracture, and in this avulsion, it suggests that about 75 to 100% anticruciate ligament is damaged, and in about 50 to 75% medial meniscus will be damaged, and lateral capsular ligament will be damaged. So therefore these are very unstable and should be referred to the orthopedics. It's Sigand, and there is another component, another fracture which can happen on the medial side of tibial head, and that's called as a reverse Sigand fracture. Reverse Sigand will suggest posterior cruciate ligament injury and medial collateral ligament, medial meniscus. Okay. Now this is C2 fracture, also known as Hangman's fracture. Eponyms, I don't like them, but examiners somehow love to ask these eponyms. C2 is Hangman's fracture. C1 is the Atlas fracture, which is the C1 is the Atlas fracture. If you look here, there is a transverse fracture all across the vertebral body going to the spinous process as well. This is a chance fracture. The chance fracture is due to forcible flexion and distraction. It's very unstable. Now this is a spinous process fracture called as Clay-Shawaller fracture. Clay-Shawaller fracture due to powerful hyperflexion of the neck. This is an interesting image which contains the classical avulsion fractures. We will see peroneus brevis will attach to the base of the fifth metacarpal, and if there is simple avulsion, it's called as pseudo-Jones. If it is happening at the level of syndesmosis, it's called as Jones fracture, and anything above is the shaft fracture. At about between 10 and 12 years of age, patients may come and you will see an os peroneum. That's not a fracture. So clinically examine the patient and then decide whether it's actually an avulsion or not. The pseudo-Jones, which are avulsion fractures, are usually treated with hard-soled shoe. The Jones and stress fracture or the shaft fracture, you need to put in a posterior leg splint, and within 1 week they should be asked to follow up. Remember, the Jones and the shaft fracture needs to be non-weight bearing for minimum 6 weeks. Now this is Lisfranc injury. If you see there's a disruption between the syndesmosis of the great toe and the adjacent toe metacarpal. Uh, if you see the normal view, there's a very minimal gap, whereas on the right side you see a displaced Lisfranc joint injury. Normally the scenario will be a patient wearing high heels or the foot held in plantar flexion and they missed a step and twisted the ankle or the foot, and this injury can happen. This is again unstable and you need to refer them to the orthopedics. Now this is a young boy or a girl who's had a twisting force on the distal radius and you got an torus fracture, or what we call it as a buckle fracture or a green stick fracture. This boy got hit with some metallic object which is rounded in shape, and because the bones are soft, it took that shape, and this is called as a tennis ball fracture or ping pong ball fracture. Now this patient has come in because of constant stressful activities, physical activities, and you see this is usually a 15-16-year-old female or male come in, and this is actually Osgood's clatter disease. If it is mildly tender, it's not an acute fracture, but sometimes they may come in with after a high jump or something like that, and it will be extremely tender and swollen. That time you need to consider that this is an actual avulsion fracture because it carries a high risk of compartment syndrome. So need to do clinical examination. You need to remember the cretol, the appearance of the bones. C is for calcaneum, R is for radial head, I is for inner epicondyle, T is for trochlea, and O is for olecranon, and L is lateral condyle. And the way it happens is 1, 3, 5, 7, 9, and 11 years of age, the ossification centers appear. This is a very classical supracondylar fracture. If you see, the radial head is also broken, and you are seeing a posterior fat pad and an anterior fat pad, which is very classically seen as a triangular sail sign, and that's always abnormal. If you don't see a fracture and you see a posterior fat pad, it is abnormal. If you see an anterior fat pad, then it's definitely if it's a sail, some anterior fat pad is always present, but if you see a posterior fat pad, that's abnormal. Now this is a classical thing. You see a scaphoid fracture over there. Yeah, so scaphoid fracture is present, so there will be tenderness on telescoping, tenderness at anatomical snuff box, tenderness on the thenar eminence, and you put them in a scaphoid cast. If fracture is not present and you get these clinical find, you still put them in a scaphoid cast and get them to fracture clinic in 2 weeks time when they will be x-rayed again. And a similar thing is this one, which is a toddler's fracture. You may not see a fracture, but the child is not weight bearing and is extremely tender. You put them in a long leg cast and get them seen in fracture clinic where they will x-ray him again in 2 weeks time. Okay. Now that's the normal appearance. On the top of the radial head sits the lunate, which is moon shaped, and on top of it sits the capitate. Now sometimes the lunate will displace or dislocate, and capitate sits directly on the radius, so that's called as a lunate dislocation. If the lunate is still in place and everything else is displayed, it's called as perilunate dislocation. Ideally it should be called capitate dislocation, but they call it perilunate dislocation. This is a x-ray of the wrist, and you see some avulsion at the back of the wrist, and that is triquetral fracture. Triquetral fracture. This is Terry Thomas sign, which is a marker for scapholunate dissociation. This is your classical neck of femur fracture, Elderly people came in with a fall and externally rotated, shortened lower limb, and that's your right neck of femur fracture. This is not a fracture, this is slipped upper femoral epiphysis, usually in the adolescent males uh, who are obese. They'll come sometimes with a limp and knee pain. You need to get the x-ray and you will see that slipped upper epiphysis. What you can do is you can draw a line called as line of Klein, and if I draw a line, it's called, sorry, well, what you can do is you can draw a line of Klein, or you can do, it's called as Tretovan sign. The line of Klein should pass through the upper epiphysis. If it's not passing, then it's SUFI, or slipped upper femoral epiphysis. Now this person has been really unfortunate to get extradural, subdural, and intraparenchymal bleed with some amount of subarach as well. So let's talk about extradural first. Extradural is lens shape, L for lens, so they have lucid interval, and lens shape, lucid interval, and it's due to abruption of middle meningeal artery. The subdural is crescent shape, and it's due to the abruption of emissary veins. Usually common in the elderly people, the subdural, and they may live normally with it because they have enough space in the cranial cavity for the blood to clot and stay there. Sometimes they may come up with recurrent falls, and that is like they may have an acute on chronic subdural. This is Mount Fiji sign. Pneumoencephalus is present, and it's Mount Fiji sign. Now, on the left side is a normal CT of the brain, and on the right side you see the suprasellar cistern and the circle of Willis where blood has been accumulated, and it is subarachnoid hemorrhage. Both these images are showing a pneumothorax. It may be spontaneous, it may be traumatic, and if you see there is some amount of tension developing over there, so you need to put in a chest drain quickly if tension develops. The algorithm for the spontaneous pneumothorax has changed, so I would strongly recommend you to consider visiting the British Thoracic Society guidelines and look at the algorithm once again. Now this is like the first image which we saw where there was subcutaneous emphysema. Quite a lot of subcutaneous emphysema is present over here, likely from Boerhaave syndrome. This is pseudo-subluxation of C2 over C3, very commonly seen. I would say not very commonly, I would say about 40% of the kids will have them. Less than 8 years of age, they will have them. So pseudo-subluxation is seen. Now this is sigmoid volvulus. What you do is you keep them NPO, you put in a nasogastric tube, and then you need to do a sigmoidoscopy. There is small bowel obstruction with multiple air fluid levels seen. Again, same thing, NPO and nasogastric tube, and refer to surgeons. This is a flexed tenosynovitis. If you look at the index finger, it is grossly swollen and will be extremely tender and will be held in partial flexion. And when you try to do passive extension, it will be very painful. So that is called as Canavel sign, K-A-N-A-V-E-L, Canavel sign. This is sickle cell dactylitis, pencil-shaped digits. There are lots of bruise on this young man or an old man, and that could be an evidence of physical abuse or recurrent falls. So you need to keep a very close, and especially these people are on some DOACs and they may bleed inside, so need to do a thorough assessment and see if they are appropriately safeguarded. So this is a person who's come in with cellulitis of the lower leg, and then they were put on antibiotics. After that they started worsening, and then they came to you, and when you palpated the cellulitis, you felt some subcutaneous emphysema. So you got the X-ray done, and this is now necrotizing fasciitis. This needs to be referred to the surgeons for debridement, and here the antibiotics will be your piperacillin tazobactam plus clindamycin, and should be appropriately referred to surgeons. This is again necrotizing fasciitis in a diabetic patient who's come in with pain in the left hip without trauma or with trauma, and when you do an X-ray you will see the subcutaneous emphysema. This needs to be referred to surgeons as well. The one on the left is the anterior dislocation of the shoulder, one on the right is the light bulb sign of posterior dislocation of the shoulder. If you look closely, this guy was punched on his face, and on the right eye superiorly you see an eyebrow sign, which is classical of orbital fracture. If you see this in real life, please consider a diagnosis of orbital cellulitis and refer these patients to ophthalmologist. They will have ophthalmoplegia, proptosis and swelling. You need to know the difference between preseptal and septal cellulitis. This is a very useful traffic light assessment for fever in pediatric age group less than 5 years of age. You need to remember color, activity, respiration, hydration and others. It's very easy to remember them, used for less than 5 years of age. Now this is multiple erythematous circular rashes on the palm. Don't shake hands with them. This may just be secondary syphilis, but we call this erythema multiforme, and the most common cause is mycoplasma or herpes simplex. Streptococcus can do it, syphilis can do it, some medications such as anticonvulsants, ACE inhibitors can do that, NSAIDs can do that, and if there's no cause known, you need to think about lymphoma or leukemia. This is a circular rash with central clearing, and the margin keeps on expanding. So this is called as erythema chronicum migrans, secondary to Lyme disease. Borrelia burgdorferi, treatment is doxycycline. They can get systemic symptoms such as bilateral Bell's palsy and heart blocks. In that case, you need to admit them and give them ceftriaxone. Now, if these are again erythematous rashes on the body, likely the child has upper respiratory tract infection about a week ago, and now they have come up with this rash. And if you look at the borders of these are like kind of raised borders. These are called as erythema marginatum. Okay, erythema marginatum, because margins are raised. That's the major and minor criteria for rheumatic fever. You can look at it. Now this lady has come in with tender red nodules on the anterior shin, and they are extremely painful. It's actually panicolitis. It is tender, rounded, nodular. So remember, the most common cause is strep pneumonia, ossipills, pregnancy. You can get it in inflammatory bowel disease. You can get it in tuberculosis, sarcoidosis. So anywhere there is granuloma formation, systemic fungus. So granuloma formation can give to erythema nodosum. You treat it by pain control and removing the cause. This guy suffers from psoriasis. He's come in with extensive shedding of his skin and he looks like a red man. This is erythroderma. They are prone to get skin infection, dehydration, electrolyte abnormalities. You need to treat them just like you're treating burns patients. This is pyogenic granuloma. It is not having pus, neither it's a granuloma, it's a misnomer. It is highly vascular. If you want to excise it, you will need to cut it from the base, and then the base will need to be cauterized because it's highly vascular. There are some bite marks on this child and some burn marks of cigarette burns. This child is suffering from physical abuse. So you need to do the safeguarding or inform the child protections. This guy is an alcoholic who's come in with deranged metabolism, unconscious, put in the intensive care unit, intubated, catheter is done, catheter, the urine glows in dark. What poison has he taken? He's taken ethylene glycol. This is the last image of the presentation. This is a young child who's come in with a popsicle stick which got pushed in by his sibling, and he's got an injury over there. We may think not much concerning, may involve maxillofacial. Well, the concern is what sits behind that part is your internal carotid. Okay, so these should be taken very seriously. The child should be kept in for observation, maybe admitted for observation, or if you got access to MRI can be done to look for the extension. But these injuries should not be taken lightly and should be referred appropriately to the pediatric maxillofacial team. Thank you for watching this video, and I appreciate your time and efforts. Please do consider joining the channel or subscribing to it. It helps me financially to make such videos for you all. Thank you once again. Happy studying and peace.